Και τώρα με μεγάλη χαρά θα ήθελα να σας παρουσιάσω το φίλο μου και χωριανό μου τον κύριο Τσιμίκα, γιατί όλοι οι άνθρωποι με τον οποίο τον βλέπω αρκετά τακτικά τα καλοκαίρια, και βέβαια τώρα θα τον δούμε από την άλλη μεριά της Καλιφόρνιας, και που είχα τη μεγάλη χαρά και τιμή να κάνουμε μαζί και να συνεργαστούμε σε μια πάρα πολύ ωραία μελέτη, η οποία έχει να κάνει με αυτά τα οποία φαντάζομαι θα μας πει και σήμερα, την Ιωάννινα Study. Κύριε Τσιμίκα, έχετε το λόγο.
Dr. Sotirios Tsimikas, and I am pleased to provide this lecture for the 41st Pan-Hellenic Congress of Cardiology. The lecture is entitled Antisense Therapeutics for Lipid Disorders of Clinical Unmet Needs. I am Professor of Medicine in the Division of Cardiology at the University of California, San Diego. These are my disclosures. Lipoproteins genetically associated with cardiovascular risk and amenable as targets with RNA therapeutics are shown here. These include LDL-ApoB, apolipoprotein A of LPA, ApoC3, and angiopoietin-like 3. The LDL-ApoB component is very well understood, and therefore I will focus on LPA, ApoC3, and angiopoietin-like 3 today. This field is relatively new, but there is significant interest in its progression to clinical medicine. These are key publications using antisense oligonucleotides that have been published on ApoC3 and Angiopoietin-like 3 and ApoA since 2014. I would like to have a brief review of the types of RNA therapeutics so that everybody is understanding of the differences in these compounds. I will mainly speak about antisense oligonucleotides today. These are single-stranded DNA molecules, and they have multiple mechanisms of therapeutic effect, and I will describe one specific one today. Now, naked DNA does not work well as a pharmaceutical agent because it's rapidly degraded. Therefore, for these to become drugs, they have to be modified both in the phosphate backbone as well as in the ribose ring. Importantly, as I mentioned, these are single-stranded molecules, and therefore they can be injected and they will travel to their site of activity without any carrier. siRNA is another form. This is small inhibiting RNA. And now this is RNA instead of DNA. It's also modified, but importantly, it differs from antisense in that it is a double-stranded molecule and uses a specific mechanism called the RISC mechanism to have its therapeutic effect. There's a third type of therapeutic, which is aptamers, and these can be both RNA and DNA, and these target proteins instead of targeting mRNA. Now, this is a relatively new field. These are the approved RNA drugs by regulatory agencies. Notice here, there are only 4 companies that have produced these drugs, and there are just a handful of drugs currently approved. In the cardiovascular area, I want to point out that for homozygous familial hypercholesterolemia, Kynamra or Mipomersen was approved. For familial chylomicronemia syndrome, Waylivra or Volanesorsen has been approved in the EU. And now there's quite a bit of work on TTR amyloidosis and cardiomyopathy by both Ionis and Alnylam. Now, a large improvement in this field has been the ability to target these molecules to the liver. And this is done by something called GalNAc, or N-acetyl-galactosamine. These are 3 galactose sugars that are modified, and they're complexed on with some ligands onto the antisense molecule. Galactosamine accumulates on proteins and is a signal to the liver to remove these proteins because they've been circulating for too long. You can add this galactosamine to your antisense molecules, and when they travel to the liver will treat them like an old protein. And therefore, through this acyl-glycoprotein receptor that you see here. The GalNAc is bound, it's internalized, and once it's internalized, the GalNAc is cleaved off. The antisense molecule goes into the nucleus. The way it achieves its therapeutic efficacy is that it finds its target messenger RNA. It forms an ASO mRNA duplex. And of course, these duplexes do not exist in nature. And therefore, every cell has an enzyme, a nuclease called ribonuclease H1 that finds these and cleaves the sense strand so you can no longer make protein, but leaves behind the drug or the antisense strand, and this can then go back and bind to another molecule. For this reason, this is an elegant mechanism and also a specific mechanism that preserves the ability to for the liver to function otherwise, but only affect that one particular mRNA. Now, if you add the GalNAc onto your compound, what it basically does is it increases the potency approximately 20 to 30 fold. And these are compounds without the GalNAc, and these are compounds with the GalNAc. This is a dose response curve. This is human data and clinical trials. You see here, this is the dose in a log scale, and this is the target reduction. So to achieve a 50% reduction, or ED50, for the LPA antisense molecule, you go from 122 milligrams out here to 4 milligrams out here. And so you can increase the potency 30-fold. Increasing the potency has tremendous advantages for a variety of reasons, including safety and tolerability. Now, let's review lipoprotein(a) first. As I think most of you know, this is a genetic risk factor, and the levels are not affected by diet or by other environmental factors significantly. It actually is composed of two proteins, ApoB100 and ApoA, and ApoA is covalently bound to ApoB100. The ApoA component is actually not a lipoprotein because it has no lipid on it, unlike ApoB, which is full of lipid. Importantly, there are oxidized phospholipids on the lipid phase as well as covalently bound to the ApoA. And we believe that LPA is atherogenic through three mechanisms: atherogenicity through its LDL component, antifibrinolytic activity through its ApoA component, and pro-inflammatory effects through its oxidized phospholipids. It has two major phenotypes: cardiovascular disease, vascular disease, and aortic stenosis, and currently there are no approved pharmacological therapies. LP(a) was first described by Kari Berg from Oslo, Norway in 1963. And as I mentioned earlier, it has multiple kringles, and it is derived from the plasminogen gene, but is only derived from kringle 4 and 5 from the plasminogen gene and has an inactive protease domain, unlike plasminogen. Now, kringle 4, through evolution, duplicated itself multiple times, and there are actually 10 subtypes, one of which, kringle 4 type 2, is present anywhere from 1 to 40 copies, and therefore, this LP is highly polymorphic in having over 40 different isoforms. In cardiovascular disease, it causes coronary artery disease, stroke, peripheral arterial disease, heart failure through myocardial infarction, kidney disease, and aortic stenosis. And notice here that aortic stenosis is a fairly large component of its clinical phenotype. Now, the plasma levels are primarily related to how much is synthesized in the liver on a daily basis. There are several clearance mechanisms, but these are secondary in that the production is really mediated by the genetics that were inherited from each parent. Now, this is a very prevalent, highly prevalent risk factor. This is data from the US, but the EU data is very similar. This is a large laboratory database. This is the first LPA level from each one of these patients. And note here that levels of 60 milligrams per deciliter, which are twice normal, are present in 20% of this population. And so for the EU, this would be 150 million people, and globally, it would be plus or minus 1.4 billion. Now, there are strong evidence epidemiologically and genetically for this being a risk factor in people without prior therapy. This is a very large meta-analysis of 1.3 million years of follow-up. And notice here that the risk is fairly flat until you get to about 30 milligrams per deciliter, then it rises linearly. Mendelian randomization using the instrument of Kringle-4 type 2 repeats has very similar data, as well as SNPs. The more SNPs you have that are associated with higher LPA levels, the higher risk you have of coronary artery disease. So you might ask, well, what about patients on statins and what about patients on PCSK9 inhibitors? Lp(a) remains a risk factor in those. This is our work, 29,000 patient meta-analysis with individual data. Note here a linear relationship again to risk once you get about 30 milligrams per deciliter. This is data from the Odyssey Outcomes trial in all baseline samples. The quartiles of LPA, the highest quartile here is 60. So in this case, these patients have CAD. Actually, 25% of the patients have twice normal values. And again, notice this linear relationship to cardiovascular risk, depending on which endpoint you look at. Now, we have been very interested in aortic stenosis and Lp(a). George Thanasoulis and his group was the first to report the genetics. We've now linked the oxidized phospholipid component to the procalcifying key entity on LPA that seems to trigger aortic stenosis. I'm not going to review this in this talk, except to point out that there's a lot of work being done in this area. Now, what about patients that we see every day in the cath lab? This is one of my patients. You see here has a very bulky atheroma and the saphenous vein graft to the circumflex. And this is what it looks like after this has been stented. A very nice result. And of course, these patients often will have distal embolic debris. This was captured by a distal embolic device. And then we took this back to our laboratory, did mass spectroscopy, and note here the oxidized phospholipid signature that's emanating from this bulky atheroma. In a different patient that unfortunately died, this is a very large fibroatheroma. Note here the brown stain is LPA, the red stain is oxidized LDL, and the brown stain here is oxidized phospholipid, highly, highly prevalent in these lesions. Now, oxidized phospholipids are predictive of cardiovascular outcomes. This is now that you see here 9 studies that have comparison of the third or fourth group compared to the first in terms of quartiles or tertiles, and the hazard ratios compared. And notice here the hazard ratios are fairly robust, particularly for stroke, over 2 in many of these studies. And so this is a very potent predictor of cardiovascular disease and events in people without prior CVD and people with prior CVD. Now, this test was developed in our laboratory and it's now clinically available as of March 2020. We are now working on having this available for Greece, and Dr. Tsimikas has expressed interest, and we will work to place an instrument and the kits that go with this in his laboratory in the University of Ioannina, so that this could be a center for referral for patients and physicians that are interested in having this risk predictor measured. Now, what about guidelines? This is the ESCAS guidelines, very important, a new step in this field. There are now 6 guidelines that recommend testing, but the ESC in particular was the most forward-looking and suggested that every single adult have an LPA level at least once to find patients that have very high levels that would have a lifetime equivalent risk typical of familial hypercholesterolemia. Okay, now let's review the most recent study. There's been 4 trials with Pelacarsen, which is the generic name. The most recent name for it was Exia ApoA LRX. This is the design and endpoints. This drug is now actually owned by Novartis, and they're going forward with all the new clinical development. This is patients that had Lp(a) greater than 60 milligrams per deciliter, prior history of cardiovascular disease, randomized to these 5 groups, treated for 6 to 12 months. And then the primary endpoint was Lp(a) levels, the mean percent change from baseline to 6 months. And then there were secondary endpoints that I'll describe in a minute. This is the key finding of the study. This is the pooled placebo group. Note a dose-dependent reduction in Lp(a). And note here that the 20 milligram every week, equivalent to 80 milligrams a month, caused an 80% mean reduction. And we had several patients that had more than 99% reduction in Lp(a). So this is approximately 3 times more potent than what's currently available for lowering Lp(a). Now, a second important finding was that 98% of patients reached goal of less than 50 milligrams per deciliter. So that not only is a very potent drug, it gets basically everybody to a non-atherogenic goal. And so this combination of findings will allow us to very nicely address the LP hypothesis, because we're going to start with high levels. Everybody then will be down to normal, essentially, and then the question will be, do they get a clinical benefit? So it will be a very clean way to interpret whether LPA lowering to a normal level leads to improved cardiovascular endpoints. Now, importantly, because oxidized phospholipids are carried by both ApoB and ApoA, these are markedly reduced. This is the absolute data. Now, also importantly, both LDL cholesterol and ApoB are reduced at a level that you see with ezetimibe. And so absolute reduction is about 16 and 10 milligrams per deciliter. Percent reduction is up to 23 milligrams per deciliter. So what that basically means is that you will have a benefit in lowering LPA, but also in oxidized phospholipids, but also in LDL and ApoB. Now, the drug itself does not affect LDL or ApoB directly. In other words, it doesn't affect synthesis. And we think what is happening is LPA particles clear slow. When you no longer can make them, the remaining LDL can clear a day faster. In other words, the LDL that would have been destined to be LPA and clear slow now can clear faster. And because of that, you have a reduction. So in these studies, despite these patients being on 90% being on statins, 50% being on ezetimibe, and 20% being on PCSK9 inhibitors, they continue to have additional LDL and ApoB lowering on top of that very, very potent baseline therapy. So what we expect in the Horizons trial, which is the phase 3 cardiovascular outcomes trial, is this. Patients will have cardiovascular disease with a prior history of MI, stroke, or PAD. They will have LPA level over 70 that you see here in the red. They will then be given Pelacarsen 80 milligrams versus placebo. They should move from the red to the green, i.e. in the normal range. And then the 2 co-primary endpoints will be evaluated, Lp(a) greater than 70 and Lp(a) greater than 90, either one of which will be considered a positive trial if it's statistically significant. This study, I believe, is like 4S was in the early 90s. That is the large trial. It's well powered. It's going to go for a median follow-up of 4.2 years, a minimal follow-up in every single patient of 2.5 years, 993 events, and should be the definitive trial for this LPA hypothesis. Okay, let me now switch to ApoC3. ApoC3 is involved in triglyceride metabolism. It's a small lipoprotein made in the liver. It regulates all triglyceride-rich lipoproteins through 2 mechanisms. One, it inhibits clearance, so it allows them to accumulate, and it inhibits lipoprotein lipase, so you cannot break down triglycerides into free fatty acids. And these 2 things lead to chylomicronemia from the diet, and also more garden variety elevated triglycerides through liver output. Now, studies have shown that both plasma levels of ApoC3 as well as mutations that lead to lower levels of ApoC3 are associated with reduced triglyceride levels and a significant reduction in cardiovascular disease events. Now, if you have this situation here and you have chylomicronemia, those patients tend to get pancreatitis. These patients that have VLDL abnormalities, IDL, remnant cholesterol, tend to get cardiovascular disease. Now I'm going to review for you two trials, for one trial for this study, for this drug, and then one trial for angiopoietin-like 3 next. This was presented by Dr. Tardif at the ESC. This is a phase 2 trial. A note here, the doses. There could be weekly, every 2 weeks, or every 4 weeks. Similar design as before, 6 to 12 months of treatment and then some follow-up. In this case, the primary endpoint is fasting triglycerides, and there's additional secondary endpoints that I'll review. This is the primary endpoint of this trial. Placebo trended up, not significantly, and you see here dose-dependent reduction up to 60% reduction in triglycerides, which is approximately twice what is currently achievable with available drugs. Now, the secondary endpoints all trended in the right direction. ApoC3, as expected, was significantly reduced in the mid to high 70s. VLDL cholesterol as much as 60% reduction. Non-HDL cholesterol reduced. No change in LDL. Trend towards ApoB reduction in a couple of the doses, and 2 of the doses they were statistically significant. And then there were increases in HDL and ApoA1. Now, the other important part of the study is 91% of the patients achieved fasting triglyceride levels of 150 with the highest dose. So again, these drugs are very potent, get most people to where you need to get them, and would be able to test very cleanly any hypothesis in a phase 3 trial. Now, because chylomicronemia is associated with pancreatitis and affects young patients, the first step in the development of this is to do a study in familial chylomicronemia syndrome, and this will ultimately replace Waylivra, which is approved in Europe. Following this, additional indications are being considered that are broader in patients that have multifactorial chylomicronemia, triglycerides over 500, and more modest elevations of triglycerides that you see here. Okay, to finish up, angiopoietin-like 3. This is another important regulator of triglycerides and cholesterol. However, this also regulates LDL as well as triglycerides, and it does that through a couple of mechanisms. One is it inhibits lipoprotein lipase, like ApoC3, but importantly, it also induces liver output of VLDL. And so if you have high levels of angiopoietin-like 3, the liver puts out more VLDL, and then it cannot break it down. You can think of this as a starvation molecule, and that the levels are increased when you need to actually put out more energy to the periphery. However, if you're not starving, this ends up being detrimental in a cardiovascular sense. Now, patients have complete loss of function of angiopoietin-like 3, have low HDL, LDL, and triglycerides. So all 3 of those particles are reduced, but they also have low risk of coronary artery disease. Now, we just finished a phase 2 trial. Daniel Gaudet was the first author. This was published in the European Heart Journal in conjunction with the ESC meeting. This one had 4 groups, three treated groups and a placebo. Very similar study design, including the primary endpoint being fasting triglycerides. This one, though, was very difficult to treat patients. They have to have 3 things. And so this wasn't necessarily designed to test the CAD hypothesis, but it looked at 2 other aspects of metabolism. So the patients had to have all 3 of these: fasting triglycerides over 150 or 1.7 millimoles, type 2 diabetes, and hepatic steatosis. So all these criteria had to be met, and then they were randomized in the study. So note here, these are middle-aged patients. They have a BMI that's elevated, they have hemoglobin A1C that's elevated, and they have a hepatic fat fraction of 17.6%. And triglyceride levels of about 3.65 millimoles, which is over 300 in milligrams per deciliter. This is the primary endpoint, somewhere between 53 and 47% reduction, depending on which dose was evaluated. And so highly statistically significant. And then all of the secondary endpoints are going in the right direction. Angiopoietin-like 3, total cholesterol, VLDL, non-HDL cholesterol, ApoB, and ApoC3, importantly, actually was also significantly reduced, probably through a secondary clearance mechanism. So this drug is licensed to Pfizer, and Pfizer is currently conducting a phase 2b study, and this will actually now choose the dose for a very large, over 10,000 patient cardiovascular outcome trial, in patients that have mixed dyslipidemia, i.e. continued high LDL and high triglyceride levels. So in conclusion, antisense oligonucleotides are ideally suited to treat elevated elevated levels of Lp(a), ApoC3, and angiopoietin-like 3. Phase 3 trials have been initiated or will start in late 2000, early 2021, and reducing levels of LPA, remnant cholesterol, and LDL and triglycerides in mixed dyslipidemias has a potential to further reduce residual cardiovascular risk and improve prognosis. So with that, I would like to thank a very large number of people that were involved in all of these trials at Ionis, Axia, Novartis, Pfizer, as well as many of my academic collaborators. Ευχαριστώ πολύ.
Thank you very much, Professor Tsimikas, for your interesting presentation. My question is, too many drugs for the lipids. We have statins, we have ezetimibe, we have now PCSK9 with RNA interference. We have now for the LPA, other for triglycerides. How many for these drugs is possible to take one patient together?
Yeah, that's a great question. You know, if you look at the patient outcomes, there's still a residual risk. And although I think for the most part, you know, except for homozygous FH, we can control LDL, the other risk factors that you mentioned are not controlled. And so we will need drugs to lower triglycerides and LPA. And the question is which one or which ones will be the best ones to do that. You know, at some point you can argue maybe to have combination therapies with these injectables. That could happen. But the bottom line is we can probably get everybody's LDL to 50, triglyceride to 50, and LPA to 50 or less. And if we do that, I think the cardiovascular risk will be markedly diminished. And so that would be the ultimate goal, is to have the tools in the physician's hands to choose from a variety of these drugs to get optimal risk reduction. And so how that plays out ultimately in the next 10 years, we'll have to wait and see.
We have Professor, the President Goudevenos, John Goudevenos.
Okay. Hi, John. Sorry, I don't think your microphone is on.
Hi, it's on. So,
okay.
What time is there now?
It's 4:21 in the morning.
Too early, but it looks like starting working.
So this is like being on call.
Θα σου πω την ερώτηση στα ελληνικά. Είχα την εντύπωση ότι όλα αυτά για τα LPA που μιλάς, αυτά αυξάνουν τη χολυστερίνη και αυτό είναι το πρόβλημά τους. Τα φάρμακα για την LPA για να τη μειώσετε. I had the impression that they increase the cholesterol. All the tablets for LPA, small LPA, little LPA. How things are now?
Yeah, okay, so here's the problem with that. I think the issue is when you inhibit the ApoA molecule in the liver can still make VLDL and LDL and send it out. And so the idea is that when you have the same number of ApoB particles, and now you get rid of ApoA, it may look like you have more LDL. But the number of ApoB particles, if anything, will be lower because of this clearance mechanism I mentioned. The issue with those measurements is that, as you may know, the current laboratory ways to measure LDL include the LPA cholesterol in there. And so it's a little bit difficult to interpret what exactly is happening to the LDL. I can tell you this, that we have developed a new method to separate the LPA from the LDL particles and get a more accurate LDL. And we're not doing that in this phase 2 study I just showed you. And there's actually no effect on the real LDL with these antisense oligonucleotides. And so it's actually not going up. If anything, it's going down because of the clearance mechanism. So I think what you'll see is when we do the large trial, this will be validated, and the drug will have 3 effects, all going in the right direction: lower LPA, lower oxidized phospholipids, and lower ApoB. And so it really would be a very interesting test of the hypothesis, and we should be able to see how much benefit that leads to in the trial.
Thank you very much again. We will see soon in Greece, hopefully the next year. Bye-bye, Sam.
Bye, Sam.
Γεια σας. Ευχαριστώ
Γεια σας.
πολύ.
Γεια σου, Sam. Γεια σου.